Hi, colleagues. Thank you for the opportunity to share with you about the ARISE webinar, looking into the effectiveness of IDIC-ASP in routine clinical practice, and again, where new insulins and combinations fit into our everyday practice with our patients. My name is Dr. Adri. I'm a specialist physician in private practice with a great interest in diabetes management. Just with type 2 diabetes and insulin, first of all, we have to look endemic in South Africa, and especially during the COVID pandemic was when we really could see how many of our patients were poorly controlled diabetics. Many patients were newly diagnosed with COVID, and oftentimes the elevated glucose levels told patients that something was amiss and they could see that this could be COVID. So if we look at this 2015 data, 2.3 million patients in South Africa are estimated to have diabetes, but many patients are still undiagnosed, unfortunately. We also know that there's a high increase in the prevalence of diabetes as our population grows, but also as obesity and poor exercise and dietary problems challenge the community, and the development of diabetes is really rife, especially in certain population groups. So the driving factor, we know that our South African women specifically are some of the most obese in the world, but also in men that there's a huge problem with being overweight. So when we look at insulin as an opportunity to treat our patients with type 2 diabetes who are poorly controlled on their oral agents, there are various factors that affect how well patients actually are willing to go onto insulin. The most important is they feel insulin will control their lives. They worry that it's too restrictive. They worry about how difficult it is to live with, to have a normal life with diabetes if you're on insulin. They've always had somebody in their family that had a bad episode. The number of injections can be a problem. And then also having to see how they have to adjust their life to the insulin management of their disease. We know that hypoglycemia is a very distinct problem, and insulin essentially can drop the sugar as low as you need it to go. But this is one of the most important endocrine emergencies, and admissions for people to hospital is evidence of hypoglycemia. And this has in the past actually been, especially with the oral agents in the older patients with renal dysfunction, where specifically the anti-diabetic drugs such as sulfonylureas caused a problem. Obviously, now we have different options on that side. But then again, insulin does come into play in this group as well. So many patients miss their insulin dosages. It's difficult to keep to a strict regimen. They don't adhere exactly as we ask them to. And it is also reported by doctors that they understand patients don't comply with the regimen that is recommended. And this is from a global survey of 1,250 physicians. So when we look at the complexity of, for example, a basal bolus insulin regimen, you can understand that just in a normal day, waking up, having breakfast, going to work, having lunch, snacks, do you go to gym, chat with friends, whatever, to try and then in between all of this, comply with a very complex insulin regimen is extremely difficult. And yet we do ask our patients to do this. So looking at good control, we have to keep this in mind, that there's this complex regimen that may affect how well patients can comply. And also, if it's too rigid, it makes it difficult for the patients to do it. And then the sphere of hypoglycemia, especially if they've had one event of hypoglycemia before, they're very much aware of how severe the side effects of this can be. So if you look at an insulin regimen that can be much more flexible, where hypoglycemia is not such a problem, of course, this would be a fantastic opportunity to treat our patients better. So let's get to IDIC-ASP. So what is IDIC-ASP? It's basically two insulins combined in one pen. So we have 70% of insulin degludec, which you know is the long-acting insulin with a half-life of about 25 hours. and then 30% of the short-acting insulin aspart, which we know well as NovoRapid. But this is now in one pen and specifically for our patients with type 2 diabetes, although there are some studies now showing the benefit of this in type 1 diabetic as well, but this is not at the moment in the label for South Africa. If we look at the effect of IDEC asp, it has a protracted steady state. So if you look at this co-formulation, there's the dihexamers of insulin degludec, the IDEC asp hexamers, and this is injected into the subcutaneous space. The phenol diffuses quickly, and then the degludec dihexamers link up via single chain contacts to form long multi-hexamers, as you can see here, and then these are released slowly into the circulation rapidly, slowly, the zinc diffuses slowly, but at the same time, the insulin aspart is diffused very rapidly. So you have this protracted effect of the degludec, and you have the rapid effect of the NovoRapid or insulin aspart. Looking at why this is such a phenomenal insulin to be able to offer our patients is that you have this protracted half-life and almost a flat action profile, as you can see on the right-hand panel. And this really translates into low variability in the day, so that the day-to-day variability is significantly reduced compared to insulins and premixes that we used before, and even basal bolus insulin with the older insulins available to us. So you have a steady state that is achieved rapidly within 2 to 3 days, as you can see on the panel on the left bottom, and then this low glucose variability as shown on the right-hand side. So this really shows us that you have an excellent profile when we look at how this insulin then acts on our patients. So on the left is the degludec profile, and you can see it's almost a flat profile, and then the insulin aspart, which we know well as NovoRapid. This is just looking at the postprandial and the basal glucose lowering effect, and the steady state that is achieved by the 2nd to 3rd days of using this insulin. So if you look at the benefit, then you're looking at both basal as well as prandial control of glucose. So it's not just, for example, with other basal insulins that you only do the basal part. This premix insulin actually gives you the ability with it to, I shouldn't actually call it a premix insulin because it's 2 distinct insulins working in one pen and allowing us to have this benefit to the patients to achieve better glycemic control. So if we see the studies and we see the benefit and how this insulin was combined, we know that studies can show one thing, but we want to be sure that the real world evidence actually does reflect this. And we had the opportunity to be part of the ARISE study that was done. And this is on behalf of all the investigators. I was the principal for South Africa, but this was done across 6 countries. And just to show you that the idea was to see, we know how Ryzodec works, IDEC asp. It is this co-formulation. And is it actually as beneficial and effective as we thought in studies in the real world? So the idea was to really use this insulin in the real world practice. So the patients weren't monitored more. They weren't given extra advice. It was purely the doctor's decision to change from whatever the patient had been on before, where they poorly controlled, and then to see how well they did with IDEC asp. So we looked at 6 countries: Australia, India, Malaysia, Philippines, Saudi, and South Africa. They included about 100 and so patients per country. They also looked at the most important factor, that it was non-interventional. So we couldn't do any extra tests. We didn't do any extra advice to patients. It was purely the doctor's decision to initiate IDEC asp to escalate treatment in the patient. They were followed up for a period of time and then to see what the results looked like. So over 1,112 patients were studied. The patients were invited, about 1,462 were initially screened and eventually completed 1,015, which means that we had a 92% persistence in the study in this real-world population in the 6 countries. And that's, again, a phenomenal result because it means that the patients tolerated the insulin very well. Looking at the baseline characteristics, this was quite interesting because the average age of the patients were 58.6 years. There was quite an equal distribution, male to female. HbA1cs in this group was 9.8%, and this is also what was reflected in the South African group. Fasting glucose of 11. The duration of diabetes on average 13.3 years. And the average body weight in kilos, 79.5 kilos and 29.2, which is a bit lower than we would normally see in the South African population alone. But of course, other countries had a different experience in this situation. If we look at previous anti-hypoglycemic treatment, it showed us that this gave us a good idea of what patients had been treated with before. And specifically the oral agents, 35% of patients this was the treatment that was elected from that side. 21% were on basal insulin only. Some were on the GLP-1 receptor agonist, 8.2%. Some were already on basal bolus insulin, 13%, and some were on another premix, 21.9% of patients. If we look at the frequency with which this was prescribed as a daily dose, it was in 52.2% of patients, twice a day, 47.6%, and 2%, which was 2 patients, 0.2%, wasn't known. So why did people decide to go with this medication? And this is really where the decision-making came in, to see what the idea was and why doctors decided to use this combination insulin. So you can see that overall, the full analysis was really by treatment group, looking at how doctors decided. And this was the amount of insulin used in the specific subgroup. So for example, overall about 35 units, make it 36 units. For those on oral agents only, they only needed 22.8 units. If they'd been on basal bolus before, they needed a little bit more, 43 units. And if they were added onto a GLP-1, 44 units. So generally speaking, quite comparable to what we saw in the trials done with IDEC-ASP. So why did doctors decide to use it? The most important was to improve the patient's glycemic control. And this was very clearly the most important reason why doctors changed and used IDEC-ASP as add-on therapy or as a change in therapy. Many then decided that this was a lower risk of hypoglycemia. They wanted to have that benefit. They wanted to have the flexibility in the dosing regimen, and they wanted to have fewer injections, especially for those on basal bolus therapy. There's no reconstitution of this insulin. The overall coverage favored IDEC-ASP as an alternative, and there were some other reasons as well. But the most important was really to improve diabetic control in this group of patients. So if we look at the change in baseline from using IDEC-ASP, you can see that overall there was an improvement of 1.4% in HbA1c. The biggest benefit was in those patients previously treated on oral agents. But again, there was even in the patient on basal bolus insulin, a 0.9% improvement in HbA1c level. If you look at basal only, a 1.3% improvement. And remember, this was only over a short period of follow-up of 26 weeks that you already saw that kind of benefit. And for patients on the GLP-1 receptor agonist, also a 1.3% reduction in HbA1c. So looking at this improvement across the different countries, we really compared very well. The best benefit was seen in Saudi, but we had a 1.3% reduction in South Africa, which was in keeping with the overall group of 1.4% improvement. So really a significant benefit when patients were treated with IDEC-ASP. Looking at how it affected the plasma glucose at fasting level, you can see that it was especially in the South African group where there was a 3.5 millimoles per liter reduction in the fasting plasma glucose that showed the benefit in our patients. And this again compared very well to 2.7 millimoles overall. Changes in body weight was exciting because here we could see that there was a distinct benefit to using IDEC-ASP. It was especially seen in the patients that had previously been on oral agents or insulins. And the only group that didn't show a significant benefit, and that was a very slight increase of 0.3 kilograms, was in the group that had previously been on a GLP-1 receptor agonist. So it had a very favorable benefit as far as weight is concerned. So one of the big reasons why people are scared of insulin is for weight gain. And here we have an insulin that causes weight loss. So a really significant benefit from that side. And then what about achieving the balance and the best HbA1c level? Well, of the 1,102 patients, 4.3% achieved at base, was not at baseline at their HbA1c less than 7. 95.7% were not. But if you look at the improvement, and this is in 26 weeks, 85% of patients still not at target, but already on the way, and a significant number had achieved an HbA1c less than 7%. What about the predefined individual treatment target? Again, looking at the improvement with the IDEC-ASP, at the end of study, 85.1% still not absolutely at target, so it means you still had to titrate, but you can see that there was a benefit in a significant number higher than when we started the trial. Looking at non-severe hypoglycemic events, again, at the start of the study, these were quite significant, and you can see that at the end of the study, that there was really a significant reduction, especially in the patients who previously on basal bolus or on basal, even on oral agents and premix. And this is a very important aspect of using IDEC-ASP as the insulin of choice. Severe hypoglycemic events, again, significant reduction in hypoglycemic events. And prior to the end of study, you can see that it was only in some with the basal bolus that still had some hypos, but the IDEC-ASP group had significantly improved as far as hypoglycemia is concerned. One of the aspects we never really look at is what about resource utilization? Because, of course, this is a very important aspect as to the cost of the insulins. So what about hospitalization, time missed from work? What about using extra strips to test because you're going hypo, for example? What about complications? And you can see this is just a chart looking at how resource utilization was reduced also with IDEC-ASP, so that people didn't miss work, they didn't have to go to outpatient visits, they didn't have to do emergency room visits, and generally speaking, they tolerated this insulin very, very well. So looking in conclusion at the benefits of IDEC-ASP, first of all, there was a significant benefit in decreasing HbA1c level. You did this by reducing fasting as well as postprandial glucose. You had a lower body weight. The patients also showed that if they were previously on insulin, they had a very much better daily basal, but also a slightly higher prandial insulin dosage. They had numerical improvement in hypoglycemic events, except for the patients who'd been on a GLP-1 receptor agonist. And really the utilization of resources was again reduced for those patients using IDEC-ASP. So there's really, in this real-world study, significant benefits to using IDEC-ASP, and it really showed to us that we can use this insulin with confidence across a spectrum of patients with type 2 diabetes to improve glycemic control. Because ultimately, treating the sugar, getting it under control, and getting to a target HbA1c level will prevent complications to our patients in the future. I trust this has been of good use to you, and I look forward to chatting with you guys again. Thank you very much.